Good afternoon, participants and our esteemed faculties. This is a PG course we arrange every year in our office for last few years. But this year, because of the scenario, we have brought for this option. And first, we have made some modules, 9 modules, cover almost all of the course, which will be required for the examination. So first one is on hip, which is the most common wrong case given for the postgraduate students. And because hip is given both in undergraduate and postgraduate, and in postgraduate examination, examiner expects all the answers asked on hip cases to be correct. So based on this idea, we have made this module, and by this time, you all know that we have 4 faculties, all are expert and senior professors of different centers, Professor Sural from Delhi, Professor Goel from Utah, Professor Imimrai from Agartala, and Professor Ekepal from IPGMR. So for the participants, if you have any question, you have got option, you set the questions that you put up and answer in between. And for the convener, for the question, you mark one faculty to answer, and if you need second opinion, second opinion. So with this few words, I conclude my welcome address to you. So let us start the program after the president, after the secretary's welcome address. Thank you.
Thank you, sir. Good afternoon. It's my proud privilege to welcome you all with Wboa PG Crash Course Module 1 on behalf of West Bengal Orthopedic Association. I must thank our President, Professor Chinmoy De sir, for his immense support to organize this webinar. First of all, I must thank our faculty, especially Professor Sumit Sural, Professor Rajesh Goel, Professor M.M. Rai, Professor Ekepal for giving us their precious time. I must thank our webinar committee, especially Rajiv Rahman, Sabyasachi Satra, Moinak Chandra, and Arnab Karmakar for their great effort. I think postgraduate students will immensely benefit from this webinar. And with this, I am handing over to our moderator to open the session. Thank you.
So by the time I think, sir, please share your screen, upload your presentation. So we will have our first talk on gate examination, which is one of the very important topic to be discussed in PG examination. And hip examination is, or any examination is, I think, incomplete without gate examination in lower limb. So Professor Sumit Sural, he is Director and Professor of Orthopedics in Maulana Azad Medical College, and he is Organizing Secretary of famous MAMC PG course for last 21 years. Sumit Sural, sir, please.
Thank you so much, Rajiv. And at the outset, I would like to thank the West Bengal Orthopedic Association for inviting me for this webinar. So in this module of hip joint, I'll be talking a little bit about the normal gait cycle to understand hip joint pathologies. And I would also talk about biomechanics to understand the lurching of the gait. And then I'll be talking about a few important gait patterns seen in pathological hip. And then at the end, I'll talk about why a person uses cane in the opposite hand. So the gait cycle, you all know, starts with the heel strike. And after the heel strike is the foot flat. And then comes the mid stance. Then is the heel off. Then is the toe off. So once the toe is off, then the stance phase ends and the swing phase starts with the initial swing, mid swing, and the terminal swing. And then again, the heel strike. So the heel strike of one limb, the heel strike of the same limb is known as one stride or one gait cycle, and it is made of 2 steps. So it's not necessarily that always a patient, the heel may strike, for example, equinus deformity. So instead of the term heel strike, the other term is the initial contact. And for understanding hip antalgic gait, we have to understand that during the foot flat, it is the loading response. That's where the entire body weight is getting loaded onto the ankle and foot. And during the mid stance, it is a single limb stance when the opposite limb is off the ground. So during this part of the gait cycle, the entire body weight is on single limb. So in antalgic gait, this part of the stance is painful. Also in this part, the mid stance, there's a tendency of the pelvis to drop on the opposite side. So I'll talk about that in the Trendelenburg gait. So let's go straight away to the, I talked about the stance phase 60%, of which single stance is 40% and the swing is rest 40%. So let's get away to the biomechanics. Now, hip joint, as you know from your knowledge of physics in school, it is a class 1 lever. So first class lever is where the fulcrum is in the center and the load on one side has to be balanced on the efforts on the other side. So we have the product of the load into this load arm. It has to balance the effort in the effort arm. So if you look at the hip joint, now when a person is standing on both lower limbs, right? So at that time, what's happening? So the body weight is 2/3 of the body weight, which is the head, the trunk, and the both upper limbs. That is 2/3 of the body weight is shared equally between the two hips, 1/3 on each hip. But the moment a person stands on one limb, so before that, I'll also mention that the center of the gravity of the body is in front of the S2 vertebral body. So when a person is standing on both lower limbs, the center of gravity falls in between this base. So the body is very stable. Now, the moment a person is standing on a single limb, that is single limb stance or mid stance, so what is happening? The body weight is now actually increased from, because earlier it was divided in 1/3 each, but now the body weight of the head, the trunk, the upper limbs, and the weight of this limb, that is also added on. So there is a turning moment of force which is created eccentrically, and because the center of gravity is also eccentric, so there is an imbalance which is created, right? So now the body has to balance that. So the hip abductors on the side in which the person is standing, that has to balance. So the product, the body weight and the body weight lever arm, if it has to be balanced by the product of the hip abductor forces and the abductor force lever arm, right? So then only there will be a balance. So now, because the balance is, there's a turning moment of force created on this side and the center of gravity is eccentric. So what does the body do? To balance it, the center of gravity shifts on the side of the single limb stance. So now from a broad base of both limbs, when the patient was standing on both lower limbs, to a single limb, it's like a cone with its which is balanced on the tip. So you can see how unbalanced it is. So to have the maximum balance, the center of gravity has to shift on the side on which the limb is now the limb is now bearing weight. So the lurch is always on the same side where the single limb stance is, because if you see the body weight lever arm has now shortened because the lurch has come here, center of gravity has come towards the hip joint. So once the body weight lever arm is shortened, so the product of body weight lever arm and the body weight, so this turning moment of force is now less. So the abductors has to have less efforts to balance this. So abductor forces and the abductor lever arm is well balanced if the lurch is on the same side. So always, whether it's a Trendelenburg gait, antalgic gait, okay, whenever a person is standing on the limb mid stance, the center of gravity always comes towards that side. So that the lurch is always on the same side, right? So look at the next example of this video. Now, this patient is standing on a single limb, normal side. We asked him to stand on this side with the TV hip. Now he is doing some trick movements. We'll avoid that trick movement for the time being. We told him not to do this, so he lurched. By lurching it, his body weight lever arm is now reduced. The center of gravity is now come towards this base. So he is able to balance by lurching on the same side. So let's see the video again. So normal side is standing. This is a Trendelenburg test actually. You can see the gluteal fold. Now the gluteal fold, when he's leaving this, it has come down. And the Trendelenburg test is positive and is lurching to have a better balance. And why was he putting the hand on this side? So that is the mechanism of using a cane on the opposite hand, which I'll talk about at the end of this lecture again. So basically, if you see what is he doing with the cane in the opposite hand, he is, see the trick movement, I'm repeating this video again. So very on the affected side, he pushes like the one pushing on the cane, and the ground reaction force helps to overturn the body moment of force which was being generated. I'll talk about this in the last about cane opposite hand in a little more details again. So the same patient, when we ask him to walk, so this is the Tillamook gait, the dynamic component of the Tillamook test, and you can see how he's lurching on the affected side. So lurch means the sway of the trunk. So the swaying of the trunk towards the same affected side to balance out. So that I try to explain by the biomechanics. And in case a person has got a bilateral hip pathology, like this child, he has a dysplastic hip. He's got multiple dysplasias in different joints. So he's got a bilateral Trendelenburg gait, which is also known as a waddling gait or a duck gait, waddling like a duck. Now the antalgic gait is, I told you in the gait cycle that during the mid stance, when the person is putting entire weight, so the hip is very painful. So he's not going to stay on this single limb for a long time. So mid stance is reduced. So that means the single support time when he's putting his weight is reduced because the opposite limb is now in the swing phase. So he will try to keep the opposite limb in the swing phase for a shorter time. So he will have a less stride length, because if he takes the longer stride on the opposite side, he has to stand in the painful mid stance for a longer time. So the opposite stride length is shortened and the double support may be increased, but the single limb support of the mid stance is decreased. And the lurch, I explained to you, because the body weight lever arm is reduced. So the product of body weight and body weight lever arm is less. So the abductors have to work less. So the forces of the hip is less. So it is less painful when he lurches on the same side in antalgic gait. And we'll see this video, how this is the painful side. It's in a double stance. But when he puts a single limb stance, here mid stance, it's very short. And the opposite stride length will be very shorter, because if he puts a longer stride length, he will have to put more time standing on the single limb. So this is a very typical of antalgic gait. This patient has got active tuberculosis, arthritis of the hip joint. And if you see from the back, you'll be able to notice the lurch better. The lurch, as I said, is always on the same side. So he's lurching on the same side. And that we explained, the body weight lever arm is reducing by center of gravity being shifted here. And so the abductor forces is less. So I'll go to the next video, that is the short limb gait. A typical description of a short limb gait is there's a vertical dip of the shoulder as well as the pelvis, because there is a shortening on that side. So during the stance phase when he's walking, there is a vertical dip in contrast to a lurch, which is a sway of the trunk, right? But in practicality, like in this patient, he's got a tuberculosis of the hip joint. There is a short limb as well as a Trendelenburg gait. So let's see him walk. When he's walking, there's a little bit of lurch. If you observe, the lurch is there. From the back, it is better observed. But when now we have given a shoe raise. Okay. So now you see that the limb length has been compensated. So actually, if you look at this, both the videos, I'll just, okay. So what I'll try to explain again in this, there's short limb, vertical dip, but there's also a lurch, because this is a combination of short limb and Trendelenburg. And when you give a shoe raise, the Trendelenburg component has increased. So what happens is, in a pure short limb, which is seen in, let's say, malunion of the tibia, or in a case where the short limb is very, very exaggerated, like in this case of proximal femoral focal deficiency, where there is a 25 centimeter of limb length discrepancy. So if you ask this child to stand on this, there's a vertical dip of the shoulder and pelvis. Okay, but when there is a Trendelenburg and a short limb combined, then the Trendelenburg component of lurch is a little bit hidden by the vertical dip. And the moment you give a compensation of shoe raise, the Trendelenburg gets more revealed. So this needs to be told to patients. For example, there were earlier a lot of patients of post-polio residual paralysis, and they used to have a short limb as well as a Trendelenburg gait, and you compensate the short limb by limb lengthening, and the Trendelenburg gait would be more visible, right? So that has to be told to the patient. Now let me talk about other types of gait and hip pathology, and one of them is the in-toeing gait, which occurs because of the increased anteversion of the hip. Now you all know that the femur has got the neck shaft angle, which is on an average around 120 degrees, let's say, and there is an anteversion angle by which if the femur is kept on a table, you can see the head is kept away from the table. So that is the angle of anteversion, right? The angle of anteversion at birth when a child is born is as much as 40 degrees, and slowly it comes down to the normal level of around 8 to 15 degrees. Now what happens? Because of the anteversion, you can see the head of the femur is contained in the acetabulum, which is retroverted. So what happens if the anteversion is increased? So the head is now trying to get subluxated anteriorly. So to now relocate the hip, what does the person do? It has to do internal rotation. So that's why the in-toeing gait comes, and that's why the children, they sit in a W position by internal rotating. And that's why most of these are cerebral palsy children whose developmental of angle of anteversion is delayed, get an internal hip gait or bilateral in-toeing gait, which is known as a pigeon toe gait, where the angle of anteversion is increased. And I'm sure you know how to measure the angle of anteversion by the Ryder's method, which probably will be taken up in the next part of the hip examination. Now, there are certain terminologies which the students should know. One is lurch. We talked about lurch is the sway of the trunk, right? Lurch is a sudden movement which is occurring, right? And list is actually a tilt. So one is, the list is like in sciatic list. Because of the disc prolapse, because of nerve root irritation, the person tilts on one side. That is called sciatic list. Or because of lumbar canal stenosis, the person moves in the front, like a simian stance or the ape stance. Whereas the term limp is basically not a medical terminology. It's an English language word, which just denotes that there is an abnormal gait. Now let's talk about very important question which is asked: why in a hip pathology the cane should be used on the opposite side? Now I told you that when the person is standing on one side, there is a turning moment of force which is created by the body weight, right? So when a person uses the cane on the opposite side, number one, what happens? The center of gravity is between the bigger base because the cane is supporting. And number two, when he pushes the walking stick downwards, so what happens is the turning moment of force is reduced, and there's an equal and opposite force which is generated by the Newton's law. And this force which is generated not only balances the turning moment which is going down, but helps to decrease the abductor lever arm, right? And so Powell has calculated that the hip pressure which is released is equal to almost 9, when he puts a 9 kilogram weight on this walking stick, almost 40% reduction in the forces takes place on the hip joint, right? So then now I'll talk about, because I have 2-3 minutes, I was told this is a 20 minutes lecture. So we'll talk about the posterior trunk bending, which is seen in the weak hip extensor, also known as the gluteus maximus lurch, which was very commonly seen earlier in cases of post-polio residual paralysis. Now for this, in the Gait cycle, I did not discuss the kinematics and the kinetics, but if you look at the kinematics, at the time of heel strike, the hip is in flexion. So what is the muscle which takes in flexion? All the hip flexors, whereas it will keep on going to flexion unless the antagonistic muscle act simultaneously. So the gluteus maximus is supposed to slow the movement of the hip flexion and initiate the hip extension. So if the gluteus maximus is weak, like in post-polio residual paralysis, so the trunk lurches back to prevent the hip to go into flexion. So this is a compensatory mechanism in weak hip extensors, and there's a posterior trunk bending. However, one should not confuse it with the Alderman gait. So here's an extensor lurch, almost this little bit of, you can see going behind. There is actually a little bit of tremor component to it, but you can see that there's a little bit of posterior bending or extensor lurch. You should not confuse this with the Alderman gait. Alderman gait is in a lumbar spine active disease where you can see there's a lumbar kyphosis, and because of the pain and spasm, the patient is having a lordotic gait. Aldermen are city councillors, right? They walk as if in a lordotic way. So this is a lordotic gait, not an extensor hip gait, which was seen in the previous video. So I think I'll talk about the last hip pathology is the scissoring gait, which is very commonly seen in cerebral palsy there is adductor spasm. And because of adductor spasm, sometimes you have a dynamic adductor spasm where on lying down, there is not much of adductor spasm, but on making the person walk, there is a scissoring because of the adductor spasm. And so the center of gravity is not only narrow, but reverse. The base is reversed. So the center of gravity, cannot pass through this inverted cone. So person is supporting this child while she's walking. So I think 20 minutes I've covered whatever I was told to cover for the hip pathology, and I end my talk here. Yeah, so thank you. Any questions?
Thank you, sir. So one question is there from Nitor Dhaka, one of the PGT has asked, please explain, sir, why to use stick on other side while having pathology on the ipsilateral hip?
So I did explain, I'll explain it again. Now, if you see this slide, I was talking about that when it's taking some time to come. Okay, so let's look at all the physics which is involved. When you're standing on both lower limbs together, the center of gravity is passing in a large base. So this body is stable. When a person is standing on one side, okay, the center of gravity is eccentric. So either you lurch this side or you use a cane, right? We talked about the lurch. Now, if you use a cane here, first of all, there's a support. So the center of gravity is in this base, again, good. And secondly, when he's pushing the cane down, so when he's standing on a single limb, the body weight creates a turning moment force, which is going in this direction. The body is trying to get unbalanced on this direction, right? So the moment there's a support and push it down, the ground reaction forces now pushes it upwards, and that force which is created, okay, turns the body moment into this side, towards the side which is on the weight bearing, right? And thus decreases the body weight lever arm, and so the patient is able to have a good support as well as relieves the pressure by the ground reaction forces. So a 9 kilogram weight being transferred on the walking stick is equal to 40% reduction in the load. Yeah. Is that clear?
Yeah.
Yeah.
Mainak, any more questions?
Hello, sir. There is a question that in the history of present illness, when there is a problem of limping with the patient, should the student or the candidate mention the side of limping, that the patient is limping on the right side or on the left side?
Okay, so you see that now the intricacies of right and left can be kept for the examination. Right? What is more important in the history is, number one is the limb, since when it is there, and whether it is a painful or a painless limb, whether the person is able to walk with aid or without aid, unaided. Those are very important, right? Because you see, in the exam, the examination is going to come anyway. So there, all this, because if you start talking details in the history only, the whole Viva will get deviated there. So better to not reveal everything right in the history. Yes?
Yes, sir.
There is a question from Dr. Sunil Dhangar. In which side do we use stick in knee and hip pathology, ipsilateral knee and hip pathology? Again.
Yes. So again, we have to look at the pathology. So what I was talking about hip, always on the opposite side. Now, sometimes in the knee pathology, when there is a genovarum, for example, osteoarthritis, right? So what is happening? Because of the genovarum, the limb is now because the knee is far away and the feet are together, so the base is narrow. So to increase the base, the center of gravity should fall with a larger base. So he can use this stick on the same side for the genu varum when there is a knee pathology, right? Otherwise, for hip pathology, it is always to be on the opposite side.
Mainak, any more question? So
I hope the videos were clear. Anything to be repeated? The Tillamook Gate, biomechanics.
There is one question. Gate should be presentation should be in the beginning or the last of the case present. Whether if he is presenting a long case, so he will start with gate or he should start with examination then end with gate.
Well, the chicken and egg story starts there. It all depends. You see, when you are, if you are in a not in an exam, suppose you are in the OPD and a patient is coming to you. The patient comes walking, isn't it? And you make the patient come and sit down next to you. So you observe the gait. So that's why always usually we start with the examination of the gait. Now, in your exam, you have to be wise, right? How confident you are with your gait. So you can start with your gait, or else you can put it at the end, because by that time you would have told all the clinical findings and all the findings would have given a good, to the examiner, what could be the likely gait. So actually, it really does not matter for passing and failing in an exam, whether gate in the beginning or at the end. No examiner looks into it that way, but the important thing, the gate has to be presented, whether at the beginning or the end, and should be accurately done.
So what are the prerequisites for Trendelenburg gate? Question from Dr. Samarjit Patnaik, Odisha. And what are the fallacies? Fallacies and prerequisite of Trendelenburg gate.
The prerequisite is not for a Trendelenburg gate. The prerequisite is for a Trendelenburg sign or a Trendelenburg test. The gate is the dynamic equivalent of that, right? So for the Trendelenburg test, that the one of the prerequisites for that, there should not be an adduction deformity, fixed deformity. So not for a gate, right? That I think Dr. Pal will be covering in the hip examination. We are mixing up the questions.
Yeah.
So if there is no other question, you can proceed on. I'll be there for the next half an hour. I can come back between if there's a question. If there are no
we want to see the Gluteus Maximus lurch gate.
Okay,
just
you want to see it again?
Yeah.
Okay. So
by this time, Dr. Rajesh Goel sir, there is a question for short limb gait. Is there any cutoff of limb shortening?
So basically, it's a compensatory mechanism by lurching backwards. Okay, because the gluteus maximus is not functioning, right? So how to prevent the flexion which is going on in the hip joint to take place, to prevent the flexion to continue to take place. So the body lurches backwards. Yes.
All right. Thank you, Dr. Suraj sir. And there is question for all panel. I think we will start with Dr. Rajesh Goel. By the time, sir, Ekipal sir, you upload your presentation, we will have some question with different panels. So please share your screen. Rajesh Goel sir, there is a question for short limb gait. Is there any cutoff value of limb shortening?
Yes. If the shortening is 1.5 centimeter up to 1.5 centimeter, there is very well compensation of the pelvis. But if it is more than 1.5 centimeter up to 4 centimeter, then but if it is more than 4 then there is a lot of problems, and the patient is not able to balance his body, and then it becomes difficult for him to walk. So these are the 3 criteria.
Professor Chinmay, sir, any opinion?
No, I didn't get the question. What is the question?
The question is whether there is any for short limb gait, is there any cutout value for limb shortening? Sir, you have to unmute yourself. Chinmay sir, please unmute yourself.
Okay, can you hear me?
Yeah, yeah.
Yes,
Hear
sir,
me?
we can hear you.
Okay, okay. If the shortening is less than 2 centimeter, this can be compensated in walking in the coronal plane movement of the pelvis. So usually this is not very tiring, but if it is more than 2 centimeter, so to compensate during walking, the muscles of the pelvic girdle will be tired, and that is actually harmful for the patient. So up to 2 centimeter is the cutoff. After that, it should be adjusted with some sutures or some other mechanism.
Sumit Sural, sir.
Yes, yes.
So
Yes,
it's
that is correct. Yes.
2 centimeter. It should be.
Yeah, so that the body is able to compensate that. That is in a normal person, okay, body with just a short limb gait, without a hip pathology, which is enough to cause more of the biomechanic derangement. Then the person can manage sometimes even up to 1 centimeter without even any abnormalities seen.
And Professor M. Rai, sir, I think has joined. Ekipal, sir, please.
Yes, yes, yes. I've already uploaded the
Start the
presentation.
slides. You can start your slideshow.
Yes, is it visible?
Yes, sir, visible. Please start your slideshow, sir.
Okay, okay.
Yeah.
So good evening all. Is it visible? I'm audible?
Yeah.
Okay. So may I start with the hip examination? This is one of the most important part which is required in the examination, as also in different type of examination, DNB, MS Ortho, and also it is also valuable for practices also in our clinical practice. So basically the history, there are some purposes to of the history taking. We have to, what is the purpose? Basically, it is the categorization of the disease. There are different type categories of the disease I will discuss. So we have to categorize which one it is. It is a broad category. It is a traumatic, it is a infective, inflammatory, like this. Next one, there is a protocol. There is some specific protocol of the history taking. Just one question has come from the students, that is I have given it. This is a body of history taking. Initially, there is a chief complaints. There are one or two, but more than one chief complaints. That is to be elaborated depending on the time frame. Which one is coming? So it's the older first. Then is the next one. Next is the latest one. Next one is the history of present illness. History of present illness should be the elaboration of the chief. There's only the three component. First component is the elaboration of the chief complaints. Next, important positive history in favor of your diagnosis, and important negative history to rule out the other diagnosis. And next one is the vital function. Vital function means the loss of weight. There is significant loss of weight, loss of appetite, bladder, bowel, and sleep. These 5 cardinal functions or vital functions. Next one is the past history. There one question has come, how the past history is ascertained. There are at least 2 types of past history must be included. There is the history of disease or history of treatment. And there must be that disease or complaint free period in between this past history and the history of present illness. Suppose there is a trivial trauma, there is a 5 years back, and after that a patient had done following trivial trauma, the pain was absolutely relieved with some taking medicine, and patient was absolutely fine for another 2 to 3 years. Following which patient develops some painful limping or painless limping. So there is a pain-free period or symptoms-free period between the incidences, past incidences, as also the present complaint. So that should be included in the past history. But if there is any connection that is continuing with the past complaint, that should be included in the history of present illness. So that is the answer. Next one is the personal history with family history. Actually, I am teaching like this: A, B, C, D, F, like this. A for allergy, B for history of bleeding or birth history, C for any history of contact, D for any drug history, E for environment history, and F for the family history, like that. Next is the men's history for the female, and also the adult female, and also the immunization history for the child. So this is the protocol. Next one is the protocol of the structure. Next, how you ascertain the diagnosis. I already told there are some categories. These are the categories: trauma, traumatic, infective, inflammatory, neoplastic, degenerative. So how you come into this diagnosis? There are 7 S questions. There's sex or age. There is starting. There's acute or chronic. Site, there is a single site or multiple site. Site means it is a right side or left side or both sides. Symptoms, that is local or symptomatic. Span, that is duration. It may be short duration or it may be long duration. There may be spread, that is progressive. Some diseases are progressive, Suppose there is a traumatic disease like fracture shaft femur that cannot progress, that cannot be a progressive disease. Whereas tuberculosis or tubercular arthritis of the hip joint, that is a progressive disease. So you have to understand which one, whether there is any history of progression or not. I will come what are the history to be taken for progression. Next one is the severity. Some diseases are very severe enough, like the malignant disease, like tubercular disease. So there's we have to understand what is there a history of severity. That means there must be some systemic symptoms. There will be some cardinal symptoms or vital functions may be affected. That is why the importance of the vital functions, that loss of weight, there is significant loss of appetite, bladder bile and sleep. So these vital signs are affected, or there is significant systemic symptom, that is disease is very severe enough, like the malignant disease, or there may be some other disease like spreading infection, or there are some other severe protein losing malnutrition like that. So they are indicated severity. So these are the 7 A's question by which we can easily categorize. Just I'm giving an example. So it's a traumatic disease. There must be some history, sudden onset history of significant trauma, following which the patient has development of painful swelling and loss of function. So this is the basic questions of the underneath the traumatic. Like infective, there must be a history of suppuration, that is a history of pus or history of high fever, that they're indicating of infective disease like that. So these are the cardinal questions that has to be asked for every disease. Like degenerative disease, I'm giving the example. Like osteoarthritis, there must be some pain following inactivity. These are the basic questions, basic features of degenerative disease. Any osteoarthritis or hip, the patient is complaining of pain just when he starts the movement. Once he is sitting, there is no pain. Once he starts movement, there is a complaining of pain, and just with continuation of the movement, the pain eases up. And if the movement is continued for long enough, at the end of the day or after walking or moving some time, pain reappears. These are the basic character of the degenerative disease. So every disease has some special characteristic history that has to be sorted out from these 7 S questions. Now I am giving special emphasis on this pain. Basically, there are several types of pain. If I am doing the life easier. That is, the pain may be categorically divided into, it may be mechanical pain, it may be inflammatory pain, or it may be infective or neoplastic. Mechanical means there is a pain is arising from the structural deformation, like the traumatic deform, there is a malignated fracture, or there is a vascular necrosis with the head becomes deformed. That may cause initially mechanical pain, ultimately that will lead to degeneration. Inflammatory diseases, like inflammatory, the specific character I will come in the next slide. I will discuss how the mechanical pain is this pain may be characterized in different ways. Next is the signs of progression. Symptoms of progression is there is the aggravation of the symptoms, like pain is gradually increasing enough, there is gradual restriction of the activity of the daily living. Initially, patient was walking for 1 hour. Now the patient is able to, after 1 month, patient is able to walk for only 10 minutes. So the activity of daily living is reduced. Or patient was get up through the upstairs, through the staircases during he is crossing the railway station. Now he is not able to do. That means there is the activity of daily living is gradually restricted. So this is the sign of progression. Another is the walking distance. The same thing. There's initially patient was able to walk for 1 hour. Now patient is able to walk for 10 minutes only, and then he has to sit down, and that is why the walking distance is reduced. So these are the features. If you take the history, that indicates that the disease is progressive enough, like the malignant disease or there's a tubercular disease. These are progressive disease. Now another question has come from the students, that what is the rest pain? Rest pain is basically a pain experienced after taking some rest, even in the daytime. So how it is different from the night pain or night cry? Night cry is basically it is once the patient is awakened in the midst of the sleep. Patient slept normally, there is no pain at all, but in the middle of the night, that's the middle of the sleep, patient is suddenly awakened, as there is a muscle spasm goes off along the inflamed joint, and the inflamed surfaces of the joints, articular surfaces becomes roughed enough during this changing of posture. So that is the night cry. That occurs only after the deep sleep. Otherwise, the rest pain can develop at any part of the daytime once the patient is taking rest. And that is basically it is a characteristics of avascular necrosis of the femoral head. And see, So how to differentiate the mechanical, inflammatory, and infective pain? Just simple. In a busy OPD, just you take the history. There are several other features. Just in this, by my suggestion is, in the busy OPD, just you have to take the history of aggravating factor and relieving factor. With the mechanical, there is structural deformation. There will be no rest pain, but the aggravating factor is the activity, and that can immediately, once the patient is taking rest, the pain will goes off. So pain, if it is aggravated by activity, relieved by rest, that is the mechanical pain. This just opposite develops in the inflammatory, as the toxic products accumulate inside in the stagnant joint, and it once the activity ensures, and that toxic products wash away, pain goes away. So there's a rest pain. Basically, there's any form of rest, even in the morning. That is a rest in the morning. That is maybe associated with the morning stiffness, and that is the relieving factor is the activity. Patient remains well during the activity. Once he's taking rest, that is the patient will complain of pain. And infective neoplastic, as the cause is constantly present, the activity may aggravate the symptoms, but there is no relieving factor unless he's taking some medicine or not. So this is the very easy way to differentiate the mechanical, inflammatory, and infective. Now another question has come: the claudication distance. How to express the gradual reduction of the claudication distance? So basically, I've already told. So just this patient will give the history that initially patient was able to walk for 10 minutes, 10 or half an hour, which is the normal time taken to reach the railway station from his home. But now he has to stop. He has to sit in between one or two times. He has to sit or lean forward to stop his walking to get relief of the pain. That is the basic expression of the gradual reduction of the claudication distance. And if there is gradual reduction of the claudication distance, that is basically, it is a mechanical pain that indicates a progressive disease. Okay. So basically, claudication may be vascular claudication or maybe neurogenic claudication, and by this means clinically how you can differentiate by taking the simple history, by easily differentiate. There's onset is very rapid in vascular, but is very slow in neurogenic. Claudication distance is fixed in vascular, whereas the neurogenic, it is variable, and aggravating factor is going uphills, and the neurogenic factor, aggravating factor, neurogenic claudication is going downhill, because during downhill, as it is going down, that causes the extension of the spine, and that extension reduces the spinal canal diameter, and that increases the pain. Okay, and the relieving factor is the rest in any form. In vascular claudication, rest in any form can cause relief of that pain. But in case of neurogenic, unless the patient sitting in slouch position, that is leaning forward, so that increases the spinal canal diameter, and that only causes the relief of the pain. Now, the general survey, that is basically there's another question: what are the points to be examined in general survey? The patient should be examined whether he is alert, conscious, and cooperative. Next, we have to see the nutrition and build. Next, the anemia, cyanosis, jaundice, edema, and clubbing. Next, the neck vein, neck glands. Next is the vital signs, that is pulse, respiration, temperature, blood pressure. How the nutrition can be examined? Basically, there are twofold. There are two ways. That is fat nutrition. How to assess the fat metabolism effect? That is skin fold thickness, just in the middle of the triceps, anterior chest wall, infrascapular region, 2 cm below the inferior angle of the scapula, suprailiac, that is just above the iliac crest in the line of the anterior axillary fold. The next is the anterior middle of the anterior thigh, and another is the mid-arm muscle circumference. Is the most important, especially in the child. Now, build is basically, there are previously it was in the asthenic, sthenic, or hypersthenic build, but that is not very significant enough. Basic scientific way is you have to see the body weight and the body height, and the body weight in kg divided by body height in square centimeter is basically there is a body mass index that indicates whether patient is a hyponutrition. That is the normally BMI is 17 to 24. 17 to 20 is normal. If it is below 74, there is a very lean and thin, it is very thinner person. It is the 24, above 24, it is overweight. Above 30 and above, it is obese. So basically, this is the basics of the build. Now come to the examination protocol. Now, prerequisites in all examination, you have to take the consent of the patient. This is very, very important. Next one is the position. It is very important. So you have to examine in a well illuminated area, and of a firm mattress or firm surface. This is very, very important. The basic prerequisites of the orthopedic examination. And next, the sequence. Now in the sequence, there are 7 broad headings. There is inspection, palpation, movement, measurement, special test, examination of the proximal and the distal joint, and lastly the last point is already there are 3 components: neurological examination, muscular examination, and the reticular endothelial examination, which is a lymph nodes examination. Now gate examination is just is well discussed. Will come again. Basically, you have stable gate and unstable gate. Antalgic gate, I always examine. I ask my students, what are the points in favor of antalgic gate? Basic 2 points. One is the painful facial expression, and is the next is the short stance face. These are the 2 points. Next, the short limb gate. Short limb gate is basically again there is a limping on the same side where the ipsilateral shoulder drops vertically down and up. This is a short limb gate. Another is the unstable gate or Tillamook gate, is already excellently described by the Professor Shudal. And basically, what are the points in favor of unstable gate or the Tillamook gate? That is basically once the patient will walk, there is possibility of falling down. That means there is that's showing the instability. Basically, there is a limping on the side, on the affected side, limping on the affected side, and there is swaying of the center of the body just in a coronal plane. That is most important. That is shoulder will move. It is not in the upward downward direction as in the short limb gate, but here the shoulder will sway in the coronal plane. That is the basic importance, and it is the body will go on that side of the affected side. So that is the Tillamook gate. Now, what is the limping? Basically, any abnormality from bipedal unassisted gait is the limping. That is the answer. Now, inspection again, there are the 7 broadening is the first point of the 7 broadening. Basically, it is divided into 3 subheading. There's attitude deformity, swelling, wasting, and the skin abnormality. Now, what is attitude? That is the basic, that is the position of the patient or the limb of the patient adopted by the patient in bed and in comfortably. That is the attitude. And what is the deformity? That is the permanent deviation from the anatomical position. So basic, this is the difference. Now we have to examine for the swelling and wasting. Swelling we have to examine in those areas where there is natural curvature, like the in front of the groin. There we have to see whether there is a fullness or not. And the wasting should be examined where there is a muscle bulk. That is the middle of the thigh. That is for the quadriceps, back of the thigh for the hamstring, and also the gluteus, the gluteal fold for the gluteus maximus muscles. Now, skin abnormalities, basically the ulcer, sinus scar, surgical scar, or traumatic scar, like that. So, if there is any discharge, you have to see whether discharge is watery or milky. Basic prerequisites, I'm showing what is the basic prerequisites of examination. The patient must lie on a hard surface in a well illuminated area. Spine should be straight, and the limb should be parallel as possible. So that should be a hard surface. That is the most important. Now, if this if I show this photograph, so can you identify which one is which patient is suffering from the hip disease? This is the normal patient, but this is the two abnormal. See, the patient is slouching position that causes that patient is allowing to increase the spinal canal diameter. So if there is a spinal stenosis or any spinal pathology, the patient will sit like that. But if there's a hip pathology, so if there is any flexion, that may cause pain. So basically, the P1 position, if the patient sits like that in your chamber, so that may be a case of a hip disease. Now, standing examination in the standing position, you can see here. You have to see basically you have to see the shoulder level of the shoulder, and the next is the anterosuperior spine. If there is an obvious deformity of the hip, knee, and ankle, you can see. From the side, you have to see again the curvature, whether it is in dorsal kyphosis, lumbar lordosis, or any obvious deformity of the hip, knee, and ankle. And basically, this is a normal position. This is normal anatomical position. The level of the shoulder will be normal. And see, this is the lordotic. You can see here the excessive lordosis. This is a kyphosis with compensatory lordosis. This is the sway back. That is the only kyphosis is there. Lordosis is normal, whereas it's the flat back. And now, if you see the anterosuperior spine, if the anterosuperior spine if it is at a higher level and then the normal side, that indicates the adduction deformity, whereas the anterosuperior spine is a lower level than the normal side, is the abduction. Why it is developed? Because see, this is the figure. This is the adduction deformity. This is the abnormal side. Adduction means that cannot be brought into neutral position. So if we have to try to keep both the limbs in a parallel position, we have to shift the pelvis. We have to shift the pelvis, so the anterosuperior spine becomes a higher level, and there is a curvature of the spine with convexity towards the opposite side. So, and the affected limb appears to become shorter. So, to conceal one truth, several lies are required. Similar thing is there, seen it is there. So, it is the adduction deformity. If the both limbs are parallel, in that case, the limb appears to become shortened. ASIS of the affected side will become higher level, and there is scoliosis with convexity towards the opposite side. So, the just opposite develops in case of abduction deformity. And see what are the inspection of the in supine position. There is the significant rotational deformities appears to become rotational deformity. Here the rotation, the internal rotation deformity. Here it is external rotation deformity. The limbs are almost normal length, but here it is apparently shortening of the limb along with the external rotational deformity. Now examination from the back, there is a hip and knee, both are flexed. So what is the, where is the disease? It is the hip is the disease or the knee is the disease. Then we have to ascertain in your Thomas test, bedside Thomas test. I will come. Now, so this is Thomas test. Before this is a prerequisite of the Thomas test. On the side, you have to see whether the light on the opposite side is visible in between the back and the couch. So this is if this light is visible on the opposite side, that indicates there is hyperlordosis. That may be a compensating feature of the increased flexion deformity. Now from the back, we have to see whether the heel is deviated. Let's see it is deviated. It is a valgus heel and it is a plano valgus foot, and see the back. So you have to see the back, and you have to see both the shoulder level, scapular level. There is a midline furrow, there is a spine, paraspinal muscles, and this is the Michaelis rhomboid. We have to see, especially in case of female. So normally what required, this is a limb body angle. Limb body space should be symmetrical on both sides. But here it is say this is little bit wider than this side. So there is a possibility of scoliosis on that. Scoliosis on list. How to differentiate? Just ask the patient to lean forward and see that this deformity is completely corrected or not. So here it is completely corrected. That means it's a list, and there's a possibility of prolapsed intervertebral disc. And see, this is the basis of the Oberst test. That is the position which is increasing. See this distance between two fingers. This is an indigenous test, can easily diagnose whether it is increasing by 50% or not. This is the basis of the SWOS test. Now limb length discrepancy, how will it clinically inspect by inspection? See the level of the heel. You have to see from the side level of the heel. If it is abnormal, there is a possibility of limb length discrepancy. Now see what is this. So this is the it may be scar or ulcer or sinus. So how do you ascertain? We have to examine this palpation. Now see what is the difference between this. This is a sinus. You can see there is a mouth is covered by the pus, whereas this is the ulcer because it is a superficial exposition of the skin and the subcutaneous tissue. It may be slap or it may be bone. That depends on the depth of the ulcer. Now palpation, you have to again there are 3 points. You have to see the local temperature tenderness. Next, palpation of the bony swelling or the soft tissue swelling. And lastly, palpation of the skin abnormality, the ulcer and sinus. If there is a sinus, where you have to see whether the sinus is fixed to the bone or not. Now the palpation after, so you have to start with the surface temperature on this carpus triangle. Then the palpation will start from the so how do there is one question, how do you ascertain, how do you palpate the ASIS? So this, you will start from the umbilicus, will come downwards. The first bony point is the symphysis pubis. From the symphysis pubis, you divert your both of the thumb. You have to palpate simultaneously both of the thumb on this side, on this side. The first bony points to be palpated is the ASIS. I have a video. If you ask, I can show the video, but because of the shortage of time, I'm not showing you. If you want, I can show you. So, and this is the how to palpate the greater trochanter. So once you identify the ASIS, so we have to mark it from ASIS to go higher up along the anterosuperior and the iliac crest, or the up to highest point of the iliac crest, and going down. What's the first bony point? It is the tip of the greater trochanter. This is a classical method. There is another alternative method from going back from below upwards. Okay, so now what is the anterior hip point? This is 1.25 cm below the meeting inguinal point. So the symphysis pubis, ASIS 1.2% below, and here you have to palpate the pulse, the pulsation of the femoral artery in this manner. Pulsation of the femoral artery, that is the vascular sign of Narad. So if when you call it is a positive vascular sign of Narad, that indicates somebody it is telling in examination it is absent. No, it cannot be absent. It may be present. It's always present. If it is a dislocation or if there is a fractured neck of femur where the neck is uprighted, there is no base, there is bony base underneath it. So in that case, you have to face difficulty to palpate. but there must be palpation is always there. So, okay, so that is the difficulty in palpation of the femoral artery in comparison with the other side. That is the basically this is the vascular sign of Narad. So once you palpate the vascular sign of Narad, the point just lateral to it, that is the 1.2% below, 1.2% below, and just lateral to the pulsation of the femoral artery, that is the anterior hip point. And just medial to it, it is the lymph nodes, that is the Cloquet's lymph node. Now, how to palpate the sinus? That sinus may be fixed to the bone or not. So how to ascertain it? We have to just pinch it, and we have to try to move it over the bone in the both axes, in this axis as also in this axis. See, there on attempt to make it to take it away from the bone, this puckering is increasing. That indicates it is fixed to the underlying structure. So if it is fixed to the muscle, that may be unable to move in a right angle to the direction of the muscle. But if it is fixed to the bone, it is unable to move in both axes. So that is how you can ascertain whether the sinus is fixed to the bone or fixed to the muscle or not. Now come to the movements. We have to examine the normal side first, then the abnormal side. In abnormal side, you have to examine the active movements, then the passive movements, and then comparison. Now comparison between the active and passive in different position is maybe required. I will come later on. Now movements. So see whether the movement starts from the neutral position or the deformed position. So for the flexion, we have to do the Thomas test. For the abduction adduction, we have to do the squaring of the pelvis. I will come. Next, we have to measure the existing range. What is the existing range? Suppose there is 20-degree flexion deformity. Now, what is the existing range? 20 degree to 100 degree or not? Next, ascertain the existing range, whether it is associated with pain or not. And depending which, we can divide the several diseases like synovitis or arthritis. I will come. So there are some special movements is required. So this is normal flexion 0 to 140 degree. And this is the case. You can see here, this is hyperlordosis. So in that, this is the Thomas test. So first test, first step is to see whether it's hyperlordosis, then gradually flex the normal limb and ask the patient to grip the normal limb till there is you have to keep your hands on this area. So I can show that the video is there. I can show it. So you have to obliterate the exaggeration component, exaggerated component of the lumbar lordosis. So by keeping your hand in between your back and the couch, just when the back is coming to touch your hand, just stop it and ask the patient to hold the limb, and then you have to just press the thigh and see whether there is any gap is present between the thigh and the bed. That is the flexion deformity. And rest of the muscle, rest of the movement should be examined by keeping your hand on the ASIS and to see the further flexion should be done until up to which flexion the ASIS is moving or not. You understand? And this is the hip examination, hip extension. Now, measurement of the flexion deformity, if it is a bilateral hip disease, that can be done in a prone position like this. So in the prone position, you have to allow both the thighs and dangling by the side of the couch and gradually extend the one side to see whether the lumbar lordosis reappears or not. If the lumbar lordosis starts reappearing, then the angle is the exact angle for that side. So that is the flexion deformity on that side. Same thing can be written on the other side. Now, if I already showed, there is one case, there is a flexion, appears to be flexion deformity of both the hip and knee. So in that case, the bedside Thomas test should be done. So in that case, this is normal side. This is normal side flexed like this till there is a exaggerated component is obliterated. Now we have to see if there is still the flexion deformity is persistent. That means it is due to the hip disease. But if there is no flexion deformity, during the flexion of this, that indicates there is no flexion deformity is due to flexion deformity of the knee joint. Now this is the other movements that you can see here. There is abduction in extension, abduction in flexion, and see what are the tips of how to know this pelvis is squared. Just I'm giving the tips. So just you have to make a join both the one anterospheric spine, and that and this is the vertical midline, and the one anterospheric spine is joined on this with the other joint. This is another anterospheric spine. So if we join like this, that will not become a 90 degree on both sides. Okay. So this is the midline. So if the angle on the both side is 90 degree and the anterospheric spine is both is in the same line, that indicates there is no there is no deformity at that point, or anterosubluxar spine is coming into the same line. Or if this line and this line is 90 degree and the ASIS is at a higher level, and that has to be moved, that the ASIS is a high level, that has to be corrected by further adducting. This is adduction deformity. Further adduction is required to bring the ASIS down to keep it at the same line. So this is the way by which you can easily understand the ASIS becoming coming or not. Now this is a Kothari's method. So in this method, without moving the hip joint, you can easily ascertain how much abduction adduction deformity is there. So this is the midline of the body. This is the ASIS. We have to join both the ASIS, and we have to make the line just at a right angle to this vertical. Okay. So this is the angle. So suppose this is the abnormal side. So this is the angle of this is the higher level. That means the adduction deformity, and this is the amount of adduction deformity. You can easily ascertain. This is the Kothari's method. Now, sectorial sign, there is rotational deformity is examined in hip in extended position and hip in there is 90-90 flex position, hip and in both the 90-90 flex position. Similarly, the external rotation is also examined in extended position, in the flex position, hip knee flex position, supine position, as also in the prone position. So if there is any change of rotation occurs from hip extended and hip flex position, that is a sectorial sign, that is the abnormal sphericity of the femoral head. Now, what is the importance of this examination of the rotation in prone position? That is basically it is done in case of child, very small child, because during the rotation there is a possibility of tilt of the pelvis. So in that case, as it is very difficult to fix the pelvis once the patient is in supine position. But if the patient is prone position, now it is very easy because of the gravity. The pelvis is automatically it has become fixed. Now we can easily examine the external rotation or the internal rotation. Now this is the rotational movement. You can see. So this is the external rotation, whereas this is the internal rotation. See, the internal rotation is much more than the external rotation. So what is the abnormality? Internal rotation is more than the external rotation, but the fair amount of rotational movement is there. That means the rotational arc is same. That indicates there is a possibility of increased antiversion. One question has come: how do you ascertain increased antiversion? This is the clue. This is one clue you can ascertain. If you examine the gait, there will be into gait. If you ask the patient to sit down, patient will sit in a television position. Now, with examine the range of motion, there will be the internal rotation will be more than external rotation, but the whole arc will remain normal. And then the special test is the Craig test or the Ryder's method. I'll show you. Now, if the fair amount of range is present but terminally painful, it is synovitis. Whereas the minimal amount of range present but whole arc is painful, it is arthritis. All motion symmetrically restricted, that means it is an infective disease. Some are grossly restricted, some are relatively unaffected. That means it is a mechanical restriction. There is a mechanical defect of the femoral head. Now, measurement, there are 3 points: apparent length, true length, and the girth. So what is apparent length? Length is which is apparently visible after natural compensation is apparent length, and that is measured from either from the suprasternal notch or the zipisternum from above, and is that is the medial malleolus, tip of the medial malleolus. In a prerequisite, it's the same. Patient should lie in a firm couch. That is, the spine should be straight, limbs should be parallel with each other, and then that has to be taken from the suprasternal notch or the zipisternum and to the tip of the medial malleolus. Now, true length, there's actual length excluding the natural compensation. I will come. There's another method is the block method. There is another foot method. There is a fixed amount of block may be placed 1, 2, 3 till the ASIS will come in the same level. That is a horizontal. Another is the girth measurement. How to measure the girth? We have to first we have to on the unaffected side we have to ascertain where is the maximum girth, and we have to mark it. Maximum girth, and that has to be ascertained from the suppose it is a 15 centimeter from the joint line. Same point is marked on the affected side, and we have to mark. And if the girth difference is more than 1 centimeter, that indicates significant wasting. Now, the true length measurement. So these are the steps. First, we have to square the pelvis. Next, you have to measure the affected limb first. Next, suppose in the adduction deformity, you have to measure the affected limb first. If the abduction deformity, you can do anywhere. Adduction, it requires some special attention. That is I've given. Measure affected limb first. then the segmental length, tibia and the femur, then draw the branch triangle, and that indicates that will make you understand whether it is a supratrochanteric shortening or the infratrochanteric shortening. Then bring the affected limb in the original position, then bring the normal limb in identical position as affected limb, then measure the normal limb. That is the way. There's a steps for the measurement of the length. Now, if it is supratrochanteric shortening, if it is a bilateral case, this is very important. Branch triangle is very difficult to draw, and because that is a fallacious. If it is a bilateral case, there's only way it is the Nielsen's line, and that has to be examined when the patient should lie in a lateral position. The one of the affected side should be up, normal side should be down, and that you have to flex the hip knee 90-90. That is, hip is flexed at 90 degree, knee is flexed at 90 degree in a lateral position. So in that case, we have to draw a line from the anterosuperior spine to the ischial tuberosity, and we have to see whether the tip of the greater trochanter is up or at the just it touches the joint. Normally, they get, if it is not the normal parameters, the tip of the greater trochanter will touch the ASIS line joining the ASIS and the ischial tuberosity. But if it is a supratrochanteric shortening, greater trochanter will go higher, and that is a very, very reliable test for the bilateral hip disease. Now, assessment of supratrochanteric, there is another question: is the Chines line or Shoemaker's line is to be drawn routinely? No, actually, it is not routinely. It's not required, because there are the reliable parameters are the branch triangle and also the Nielsen's line. These are the not reliable, because we are relying on the umbilicus, which is not at all a reliable point. So that is the Shoemaker's line. That is if we line joining the greater tip of the greater trochanter ASIS and the both sides, normally it will meet in a midline above the umbilicus. If it is supratrochanteric shortening, that will come the other side, not in the midline, below the umbilicus. If it is a symmetrical shortening, that will cut in the midline but below the umbilicus. So there is a Shoemaker's line, but it is not at all reliable. So that is not required. Chines line, there is a one line is joining both the greater trochanter and both the ASIS, and normally it should be parallel. But if it is reduced on that side, that indicates supratrochanteric shortening. But it is also not the hefty patient is not very reliable. Now, for the lower child, it is a very important. This is the Alice test, when the patient will lie in this manner, and both the heels in a straight line. We have to see from the side also, from the front. If it is on the side, there is a unequal length, that indicates that there is a femoral shortening. Even from the front, if it is unequal length, that indicates a tibial shortening. The same thing can be done in this manner for the adult, but this is not reliable enough. Now, for the if the true shortening is equal to there is apparent shortening, there will be no coronal deformity. If the true shortening is more than apparent shortening, that is abduction deformity. Whereas true shortening is less than apparent shortening, that indicates adduction deformity. This is a normal, but there is a possibility of deviation. Now, special tests should be specific for specific joints. Suppose for the hip joint, the special tests are given below, like Tillamook test, that indicates that actually ascertain the power. That is abductor muscles, leverum, the femoral head and neck, and the fulcrum of the hip joints. And the telescopic for stability in the adult and stability test for the child. That is I will come later on. And active straight leg rising is very, very important. That is the structural integrity of the femur, quadriceps, really the sacroiliac joint, and the Steinfeld test. There is active straight leg rising against resistance, that indicates the Steinfeld test, or is it the fulcrum test? Is there any supple abnormality of the femoral head and neck, like the stress fracture, that will become positive? Now, the prerequisites of the Tillamook test, there must be. This is one question asked by some students. Basically, that must be bipedal stance. This is very important. There will be no coronal plane deformity, and that will cause fallacious test. So, if there is abduction adduction deformity, ASI is at the higher or lower level, that indicates there is that will lead to fallacious deformity. And hip flexion, that must be at least 30 degree. If there is no hip flexion, like a 10-degree hip flexion, 0 to 10 degree or 10 to 20 degree. So in that case, unless there is the hip flex 30 degree, that will not become that the elevation or depression of the pelvis cannot be appreciated. So hip flexion, that must be at least 30 degree. Another important point is spinal muscles, especially the quadratus lumborum, must be intact. If the spinal muscles are weak or paralyzed, in that case it is very difficult to maintain a balance. So these are the fallacies, and if these prerequisites are met, the patient is standing with single stance for at least 30 seconds. This is the another most important practical prerequisites for Tillamook test. Okay, so if it is very painful or patient is not able to stand for 30 seconds, in that case the indirect Tillamook test should be done. And in that case, see, this is the prerequisites I've already told. Patient examiner should sit down on the back of the patient, and we have to keep both the thumb on the dimple of Venus and both the fingers on the highest point of the iliac crest, and ask the patient to keep the one limb off the ground and to see whether it is going up or not. If it is going down, that is the positive. That is indicates the patient is not unable to stand for 30 seconds, and that is there is going down and is a positive Tillamook test. Now, if it is a very painful, patient is not unable to stand for 30 seconds. So this is the basis of the indirect Tillamook test. That indicates that if because of severe pain or instability, patient has to lean his body on that side. So in that case, so that can be tested. That indirect Tillamook test can be done by keeping the examiner's hand, ask the patient to have support on the examiner's hand. So in that case, there will be much more pressure will be exerted on the examiner's opposite side hand, because this side is the abductor is not working properly. So the body will try to fall on that side, and that can be compensated by giving extra pressure on that hand over the examiner. Examiner will feel the extra pressure on that side. That indicates the opposite side is abnormal. There is an indirect Tillamook test. Now the demonstrates the axis deviation, gradual flexion of the hip. If there is a gradual external rotation, that indicates there is some slip capital femoral epiphysis. There is the epiphysis is shifted posteriorly and downwards. That causes excessive external rotation, and that is the axis deviation. And the Steenfeld test, that is I already told, is the fulcrum test. So any supple pathology of the neck and the femur, that may be positive. Now test for the anteversion is very important. This is the Rader's method. I already showed you the Rader's method of the this is the test. That is we have to make it prone position. Next, you have to gradually internally rotate the femur. That is gradually shift the leg on the outer side, so that the internal rotation till the greater together becomes prominent. We have to keep the other hand on that side, and we have to just internally rotate till there is a maximum greater together become maximally prominent. And in that case, the angle between the vertical with the leg, this is the angle of anteversion. Okay, and this is the another test. You can easily ascertain which one is the this is the basically the Rader's method Craig's test. Another is test if the neck of the femur is fractured. Normally, if you rotate it, this is the basically rotation, and if you feel the greater trochanter usually that rotates in the arc of a circle. But if it is the neck of the femur fracture, the greater trochanter will move excessively and in the axis of the femur. So that is in different way, and that the rotational pattern is different from the other side. That indicates that the intercapsular neck femur fracture. And so see, this is the telescopic test is for the adult. So the hip in 90-90 flexed, and we have to keep the other hand thumb on the anterosuperior spine, all the fingers on the greater trochanter. Just we have to assume the 10-degree adduction should be required, and with push and pull, you have to feel whether there is any crepitus is felt on that side. This is the telescopic test. But if it is a classical telescopic test, but if the hip movement is not possible, 90-degree hip movement is not possible, that can also be tested in 60 to 80 degree or less than that. And the Barlow's test, I'm not going into detail. This is for the pediatrics. And see, this is the flexion adduction, and the internal rotation. Fadid. This is the flexion adduction internal rotation fadid in the supine position. And see, this is the flexion adduction internal rotation in the lateral position. You remember, this is a two test. Fadid test. This is basically this is the test for the labral injury. This is the impingement test. If we make the sudden movement, flexion adduction internal rotation, that will cause severe pain at that area. That indicates there is an anterior labral. Just opposite, it may be posterior labral injury. And see, this is the lateral position, and the same thing can be done. The flexion adduction and internal rotation, that indicates there is some piriformis is stretched enough, and there's a piriformis syndrome. And this is the flexion abduction external rotation. This is the Fabier test. Flexion abduction external rotation. This is basically for the sacroiliac joint. Now this is for the Oberst test. In that case, patient is asked in the lateral position. You have to make the other limb maybe extended or the flexed of the hip. And this is the disease dip. This dip initially you have to keep it in extension, abduction, keeping the knee flexed. The extension and abduction, and just allow it to make it adduction. But if there is the iliac, the tensor fasciolata that is very taut enough, iliotibial band is taut enough, that will cause the gradual adduction will not become there, and then it will remain abducted. That is positive Oberst test. I'll have the video I can show you. This is the test by which we can examine the iliopsoas or the lesser trochanter avulsion. There is a patient will ask to sit and ask the patient to flex against resistance. If the patient will complain of pain, that indicates there is some there is inflammation at the iliopsoas insertion, or there is a fracture of the lesser tuberosity. This is the straight leg rising against resistance. This is a Steinfeld test. Examination of proximal and distal joint, at least 3 cardinal features should be examined: the deformity, tenderness, and the movement. And a special test is a sectorial sign. Axis division already it is examined. And for the lastly, there are 3 points for the examination of the lower limb. Always examine the gait. That should be examined examine the gait first, then followed by the other examination. And for the hip examination, always ask for the parectal examination. And for long cases, the other system must be examined later on. Now, this is a summary. I can ask what is the disease. At the end, we have to make the summary like this: a 7-year-old boy presented with painless limping of the right side for last 8 months, with frequent painful episode after running or playing, without history of significant trauma. That the history of fall on the ground with pain at groin at 5 years age, relieved completely with medication. But there is no fever, no pain in other joints, family history, no significant family history, and there will be complete immunization. On examination, there will be short limb gait, no deformity, no wasting, no tenderness around the right hip. All motions are full except the abduction and internal rotation, with 1 centimeter true and apparent shortening. Both are equal. Special tests are negative, and the other systems are normal. So basically, all of it examined. So this is basically this is a provisional diagnosis should be a leg curl for this disease. There are several other differential diagnoses like congenital coxa vara, developmental coxa vara. There is a pathological fracture of any congenital any neoplastic, benign neoplastic disease, or there is some monoarticular rheumatoid. So this is the basis. Another case is a 38 years female of poor socioeconomic status, complaining of gradual onset pain in her right groin for 9 months, without history of trauma, pain other joints, with history of gradual aggravation of pain, especially disturbance of the sleep due to pain, restriction of daily activities with loss of appetite and the weight loss. So these are suggesting severity of the disease, as also there is some progression of the disease. So on examination, there will be Antarctic Gate, that is a flexion, adduction, interrotation deformity of the affected side, wasting of the quadriceps and the gluteal muscles, apparent shortening of a right lower limb, anterior hip point is tender, direct trochanter at a higher level, all motions of the right hip painful, restricted, with whole arc is painful. Apparent length is 3 centimeter short and true length is 2 centimeter short. 3 centimeter wasting of the right thigh. The active straight leg rising test is painful, and this is significant enough for provisional diagnosis of tubercular arthritis. There are arthritis of the hip. There are several other diseases. There are different common differential diagnosis like the tubercular osteomyelitis. There is some subacute osteomyelitis of the subacute pyogenic osteomyelitis of the proximal femur, or there are some other there are bleeding diathesis if it is a younger patient. Now another case, it is a 59 years old male presented with inability to walk due to pain for last 7 months, following fall on slippery surface, treated indigenously with some medicine, without history of fever, pain at rest, pain other joints. So easily you can easily understand that may be a case of there is some traumatic disease. With trivial trauma, traumatic disease. So on examination, this is a bipedal gait, not possible. Bipedal gait is not possible. So right lower limb appears to become shortened, externally rotated, with wasting of quadriceps. No tenderness around the hip. Greater trochanter is at higher level. Range of motion, active SLR is not possible. Passive range of motion is painless with external rotation, and adduction is more on the right side, which are painless. 2 centimeter thigh wasting, telescopic test positive, Tillamook test positive, and Distal sign is also positive. So this is a case of, this is a provisional diagnosis. It is a non-union of intercapsular neck of femur. Okay. Thank you.
Thank you, sir. I think there are a few questions in YouTube, so we can take.
Yes.
So first is that Alok Sharma asked that in which position we should start the examination.
Yes, in which position then start mean examines, you have to examine from first you have to gait, you have to examine the gait, then standing position should be the first one, then the supine, then prone position. I think in my opinion standing should be one, because gait should be examined first. Why my side is, if we keep the gait in the last one and we continue the examination by movement, tenderness, all of that, some subtle pain may become painful. Painful joint may become painful. So always examine the gait first, then the standing position, then the supine, then the prone position.
Okay. So in inspection,
Hello. Hello.
swelling or
yes, Dr. Rai.
Hello.
Professor Rai. Professor Rai. Yes.
Yes, sir. We can hear you.
Yeah. Can you hear me?
Yes, sir. Yes,
Can you
sir.
hear
Yes,
me?
yes, sir. Yes, sir.
Yes.
Yes, sir.
But you are not visible.
I have 3 comments.
Yes, sir.
I have
Yes. Please, sir.
I have 3 comments. I
Yes,
have
sir,
3
please.
comments.
Please.
Firstly, to start with, rest pain. About the rest pain, you know, the patient should be in supine position. Rest pain, actually, it is assessed while the patient is getting pain in horizontal position, and at that time, the vascular blood flow to the foot or the lower limbs is reduced, and the patient gets pain. If the patient is in sitting position and the limbs are hanging, then blood flow increases and patient will not get. And can you hear me?
Yes, sir. Yes.
Yes, yes, you are right. You are right.
Hello, can you hear me?
Yes.
Yes, we are hearing,
Yes, sir.
sir. Please.
Okay, that is one point. And second is that in general survey, how many points Dr. Pal has nicely demonstrated and mentioned all the points. But one thing I like to mention, that pallor or the anemia is one of the most important.
Yes, yes, yes. You are right. Actually, I have
And
mentioned the anemia. It should be pallor. Clinically, it should be pallor.
Thirdly, about
I think MMDI sir is answering. Rajesh Goel sir, there is one question. What is difference between mid-inguinal point and midpoint of inguinal ligament?
Yes. Actually,
there is a difference between.
Yes, I'm coming. So if symphysis is the midpoint between the symphysis pubis and the ASIS. Midpoint between the symphysis pubis and the ASIS is the midpoint, mid-inguinal point, and it is the midpoint of the pubic tubercle and the ASIS is the midpoint of the inguinal ligament. Okay.
Why not? You can ask question with different faculty now.
Yes. So I think
Yes, there is one question whether the Neletons line needs to be drawn routinely, Professor Pal sir.
I've already told it is basically helpful for the bilateral hip disease. It is a bilateral hip disease. Neletons line is important, but you can do if you have time, enough time, you can do that. There is no harm. But it is specially helpful for the bilateral hip disease.
Okay,
yes. And there is another question. In case of sequelae of childhood illness like Perthes disease, whether the disease is to be considered in present illness or in past illness.
Disease means history of previous trauma. History of previous trauma. That means in all Perthes history, Perthes disease starts with the history of previous trauma. But the patient will become absolutely symptomless. So I already mentioned it. If the past incidence, disease, or any treatment has no connection, there is some symptomless period between the past illness and the present illness, that can be considered as a past illness. But if the disease is continuous with that incident, that should be included in the history of present illness.
And what is the opinion of all the faculty to know that in inspection, whether we should have swelling or prominence?
Which one, please repeat this?
In inspection, whether to say swelling or prominence, which is the correct word? I think.
Okay. So if there is a if there is some natural curvature, suppose the scarpa triangle. Normally the scarpa triangle is concave. If there is a fullness, you can measure there is a fullness of the scarpa triangle. There is no harm at all. But if there is a significant swelling, suppose there is some tumor which is already the surface is elevated, then in that case you can tell that is a swelling. So it depends on the situation. If the fullness, if the normal concavity becomes full, then you can mention it as a fullness. But if it is a significant swelling, circumscribed swelling, then there is some points of swelling to be mentioned. You can tell it is a swelling. That depends on the situation.
Sir, one question is from Rajasthan, and it is to Rajesh Goel sir only. They have asked you, Rajesh Goel sir. Yes. So, what do you mean by squaring of pelvis? They are asking, what is squaring of pelvis?
The squaring of pelvis is very important. You must learn it. That squaring of pelvis is very important for measuring of the coronal deformity. And from this point of view, both the anterior superior iliac spine should be in the same line, and that should be in the perpendicular plane to the Ziffy sternum and this. So it should be squared. Then only you can measure the coronal plane deformities. This is the basic requirement. This is basic prerequisite of measuring all the coronal plane deformities.
And another thing is, question is with Rajesh Goel sir. Sir, in fixed pelvic obliquity, how do you measure the coronal plane, the limb length discrepancy? Fixed pelvic obliquity.
Fixed pelvic obliquity, it is difficult. It is difficult to measure the limb length discrepancies. Yes.
Chinmay Day, sir.
The answer is same. It's very difficult in fixed obliquity because when we like to measure the true length, the upper point should be at the same level. Then only you can compare. In pelvic obliquity, cannot do that. It's not possible.
Another question is from Sir Nepal.
I want to.
Yeah, please.
For fixed pelvic obliquity, there is no necessity to correct exact the true length. When it is required from during the replacement surgery. So in that case, we have to require some functional length correction. So there is the importance of block. There is a block method. So just we have to make it both the limbs parallel, and there should not be any there is a awkward movement of both the limbs. In those cases, basically the block method is required. This functional limb length correction.
Rajesh Goel sir, another question is for you from Nepal. They are asking, while measuring the branch triangle, do you need to square the pelvis?
No, it is not required. But branch triangle has got very good importance to know the suprapelvic shortening or landing or whatsoever it is. So it is very important to draw the branch triangle in all the cases. Okay.
Mainak, any more question? Unmute yourself, Mainak. Unmute yourself.
Another question is that what is the significance of posterior joint line tenderness in hip? As it only.
Just repeat now.
What is
repeat
the
significance
of posterior joint line tenderness in hip?
Yes. Basically, there is no posterior joint line tenderness. There is no posterior joint line tenderness because what is joint line tenderness? That means the tenderness, that means any pathology which becomes superficial at that point, that is the joint line tenderness. Anterior hip point is justified because any hip pathology becomes anterior, but there is no posterior hip point. The point which is considered in some books, it is required is the posterior point, but that is not a posterior point. That is basically a sciatic point. Sciatic point, once the line is joining the ASIS with the ischial tuberosity, and there's a medial 1/3 and lateral 2/3. The lateral 2/3 and medial 1/3 of the line joining the ischial tuberosity and the ASIS. That is the basically the point of sciatic now, and that is basically it is a sciatic point. And in some bodies is fallaciously it was mentioned as a posterior joint, but there is no posterior joint line.
There is a question from Dr.
Hello.
Yes, sir.
One question is here. Huh? Hello.
Yeah, please, Sabasaki, please.
For Dr. M.M. Rai, sir. Sir, there is a question that why the squaring of the pelvis is done and why both lower limbs are placed in identical position for measurement of the true length. Why the squaring of the pelvis is done and why both lower limbs placed in identical position for measurement of the true length.
I think MMRI sir, some audio problem
Question
is
is
there. Well,
not
sir,
audible.
if you can take this question.
Audio problem. Can you hear me? Can you hear me?
Yeah, we can hear you, sir.
One question was there, whether the Nelton's line and Brand's-Tankel both should be drawn. The answer might be the both should be done because Nelton's line is much more reliable to assess there is supratrochanteric migration or shortening. Both should be done because Nelton's line, it is drawn taking two reference points of a single bone.
Sabsachi, can you repeat your question?
Yeah.
No,
Sir, can you hear me? Sir, can you hear me?
Yeah.
Hello. Hello.
You can tell your question to Professor
Why both lower limbs placed in identical position after squaring of the pelvis for measurement of the true length?
Well, sir, please.
Yeah, it is the basic principle of the mathematics that if you want to measure any of the thing, then if you want to measure any two things, then both the things should be in the same identical position. Then only you will be able to know the correct measurement. Similarly, in case of abduction deformity or fixed adduction deformity, if you want to know how much is the true shortening, or how much is the true lengthening, for that you have to keep both the limbs in the identical position when measuring. First of all, you measure the affected side. In that case, what will be the position of the fixed abduction or the fixed adduction? Then you take the normal side and you keep the limb in the same position as it was in the affected limb. Then only you will be able to get the proper length or proper shortening or the proper lengthening. That is why it is required.
Also,
Professor Pal, you want to say something?
Yes, I've drawn this diagram. Can you see that? Ideally, the true length should be measured from the center of the hip, center of the femoral head to medial joint line. But actually, we are measuring the anterior iliac spine, which is not at all a property of the femur. So there is making a triangle. So you can see that making a triangle. You can see here. So ideally, we should measure the medial arm, but at the instead of that, I am making the hypotenuse. So if that hypotenuse is make a fallacious. If we make a adduction, that hypotenuse increases its length. If it is abduction, the hypotenuse reduces its strength. So there is a error factor. The same error factor should be attached on the normal side. So just similar, just why if you want to have some card which is not from your sweet shop, so and they what they will do, they will keep one empty pot on the other side. So just to make the equal weight. Same thing. So we are adding the same error on the other side. So that is why it required to make it identical, and first we have to correct it. The AS has to be. So now another question: how a square requires 4 points. Just we are changing the addressable aspect. How it can be squared? Can anybody answer this? I have answered, because the square requires 4 points. What the other 2 points? We are manipulating only the 2 points. The other 2 points is the PSIS. We are not changing, because unless it is become severe disruption of the sacroiliac joint, so these points becomes fixed. So they, among the square, these 2 points becomes always fixed. Only 2 points which is mobile in anterior, I'm changing that. So squaring is required first. Next one, as we are fallaciously we are measuring the hypotenuse. This error factor is deliberately added on the normal side, and for this we have to identical position is required.
Okay, sir. One question.
So another question is there.
History is that in case of bilateral avian cases where one disease is more severe, one disease is mild. So how to elaborate the full history? Suppose one hip has been treated by a replacement or any surgery. So how to elaborate that, and whether to include everything in a present illness or in past illness? So there is a query regarding that.
Anybody that I can?
Yeah. Yes, Chinmay sir.
Chinmay sir, you need to unmute yourself.
Yeah.
Yes, sir, you go ahead.
Okay. As already Dr. Paul has said, if the presentation has got the legacy with the previous problem, it is the same disease. So avian is a continuous process, and in the present illness, you should mention about the treatment also. So replacement is a part of treatment at the present illness. So in both the situation, one side is already treated and other side is not treated. So it should mention in the present illness, including the treatment in form of THR.
Absolutely.
Sir, there is a question.
Sir, one question is there.
When can shortening of hypotenuse of the branch triangle happen? Please explain. When the hypotenuse of the branch triangle can be shortened.
So if there is any internal rotation, if there is the internal rotation of the any cause which causes internal rotational deformity, that will lead to reduction of the branch triangle, along with the shortening. If there is shortening with internal rotational deformity, any cause, that will lead to reduction of the hypotenuse of the branch triangle.
Okay.
Yes.
One question.
Moinak.
Yes,
it is
sir.
The dislocation of the hip joint. If anterior dislocation, it increases. In posterior dislocation, the hypotenuse is shortened.
Exactly.
Okay, sir.
Exactly. It's a flexion, abduction, extra internal rotation. So that will lead to reduction, and with the flexion abduction, that will increases. Absolutely, Dr. Dey.
Sir, another question is here. Why does rotations of the hip increase in 90-90 position? Why does rotations of the hip increase in 90-90 position?
Yes. Well, sir.
Yeah. In 90-90 position, all the ligaments of the hip capsule are relaxed. That is why it is increased. While in case of straight leg, it is not, the anterior iliofemoral ligament is very taut. So it will not allow the rotational movements to occur. That is why we should do it in 90-90 position.
Also, any addition?
Another important anatomical explanation is, if you see the anteroposterior radiograph, what is the shadow of the anterior wall and the posterior wall? Anterior wall is little bit shorter than the posterior wall, isn't it? So if there is head becomes flat, so which part of the femoral head is defective? The anterior superior lateral aspect, because the anterior superior lateral aspect of the head is defective. So once there is some in extended, if we rotate it, it will becomes averting the excessive extravasance of the femoral head is going to become restricted by the anterior rim. Once it makes it 90 degree, it will go inside the femoral, inside the canal, acetabular canal, and that will cause increase a little amount of increased internal rotation. That is the basis of that is sectorial sign.
Yeah, two causes. I think soft tissue and bony, both are important. Yes. So there is a question: how will palpate anterior hip point? Chinmay sir.
It's already mentioned. First, you identify the mid-ingular point. This is the midpoint between the symphysis pubis and anterior spine, and it is confirmed by palpation of the femoral artery. Palpation of the femoral artery. So this meeting point, crossing of the femoral artery posteriorly and inguinal ligament, from this point, you go 1.5 centimeter below along the femoral artery and 1.5 centimeter out laterally. So this is the entry point. Why it is chosen? Because this part of the femoral head is not covered by the muscles forming the floor of the femoral triangle. So it is in direct contact with the skin and fossa. So if the joint is inflamed from this point or this area, you can have the tenderness. So this is the anterior point. Crossing of the femoral artery, and anterior inguinal ligament come 1.5 centimeter below and 1 centimeter laterally. So that is the anterior point.
I think there are few questions which are related to Bryant's triangle. So I request Professor Pal to explain once more the significance of Bryant's triangle, and question is asked whether the student should explain all the three compartments of the triangle or only the base is important. So this part is also, I think, request you to clear that out regarding the Bryant's triangle.
Bryant's triangle, actually, basically, the Bryant's triangle, ideally, it should be drawn after the ASI should be just that is a true length, isn't it? So, basic prerequisite of true length is first squaring of the pelvis. We have to square the pelvis first. Second one, we have to draw already you have to mark the anterocipitral spine, tip of the greater trochanter, and that is a vertical, imaginary vertical line from ASIS to downward, and imaginary horizontal line from greater trochanter to that vertical line. So they are basically the base of the Bryant's triangle indicates the supratrochanteric shortening, and the hypotenuse, which is the one that indicates the rotational component. So if there is some internal rotation that reduces that hypotenuse, if it is the external rotation like the anterior dislocation of the hip, that increases the hypotenuse. And if there is a base, if there is supratrochanteric shortening, sometimes the base will be reversed. So there is a reverse Bryant's triangle. That's a significant supratrochanteric shortening. So that may be the possibility. So basically, this is the basis of the Bryant's triangle. So the base indicates the supratrochanteric shortening, and the hypotenuse that indicates the rotational deformity. That there is whether the tip of the greater trochanter is coming closer to the ASIS or not, or going away from the ASIS. So that is the basic of the Bryant's triangle.
And one question is how to take supratrochanteric and infratrochanteric measurement. Is there anything is required, and how to do it?
Yes. So actually, supratrochanteric and infratrochanteric measurement, that is basically it is a true length. So first prerequisite is the squaring of the pelvis. Then we have to make it. Suppose I already shown the adduction deformity. We have to measure the abnormal side first, then the normal side. So in the abnormal side, suppose we have to correct the that is the squaring of the pelvis. Both the ASI at the same level. Then you have to mark the ASI to medial joint line of the knee joint. That is the leg. That is the thigh component. And from medial joint line of the knee to tip of the medial malleolus is the leg component. From the thigh component, we have to draw the Bryant's triangle. The base of the Bryant's triangle indicates the supratrochanteric length, and from the tip of the greater trochanter below onward. So if we reduce that, deduct the base of from the total length, that may be the infratrochanteric length. Okay.
Okay.
So there is a question. In bilateral coronal plane deformity, how to assess which deformity is more?
Well, it is difficult in bilateral coronal plane deformities.
Yeah.
It is difficult. Bilateral coronal plane deformity, how to measure it, isn't it? So that is, I have encountered one case where there is a, I think Arnav, you can remember that one case has become admitted in our basis scheme in ankylosing spondylitis. One side is abducted, one side is fixed abducted, one side is adducted. Isn't it, Arnav? You can remember. So say in that case, how to measure the how much abduction deformity? A simple answer is the Kothari sign. Simple answer is the Kothari sign. Without moving the hip joint, Just you have to measure the Coteries angle. That will indicate how much abduction is there, if where the endosylvial spine is the lower level, and then where is the adduction deformity, where the ASI is at a higher level. Simple.
Okay. So one question is there. Is there any posterior hip point?
That is discussed.
That is already
discussed.
Or no, repeat it. Just repeat.
Yes.
Okay. So to go ahead, sir, there is a question that if the
Sir,
hip is flexed up to 90 degree,
Yeah.
we draw the Nielsen's line or what?
No, it's not. I'm not getting your question.
Sir, if hip is not able to flex up to 90 degree, whether Nielsen's line should be drawn or not?
No, if it is possible to flex up to 90 degree, then there's no need to draw Nielsen's lines.
If it is not able to flex up to 90 degree, so you
Yeah,
should
yeah.
draw it.
No, yeah, yes, you should.
Okay, okay.
So there is a question to Professor Pal sir. Does the ASIS level get reversed in supine and standing positions in cases of coronal plane deformities?
ASIS position will change in coronal plane deformity. That is a basic thing. Now my take is I don't examine the ASIS in standing position, because in standing position there may be fallacious because there is some natural compensation. I always examine the ASIS in supine position, because that is the best position to examine, where there is a natural compensation, that means the limb length discrepancy becomes completely obvious. But if you examine in standing position, it may be fallacious because the nature will try to compensate. You understand? So always my take is always examine the ASIS in a supine position.
Okay. There is one question regarding the palpation of the SI joints. What is the landmark? So request Professor Chinmay Desai to take this question. Palpation of importance of palpation of SI joints and how to do it.
Unmute yourself, sir.
If you go along the inguinal ligament, the first bony point or bony area, it is the anterior spine. So it has got some importance. One is to draw the branch triangle, already told, and other is palpation of the area, because it's attachment to the sartorius muscle, and sartorius muscle is often injured, particularly in the footballers. So this area should be palpated for irregularity and tenderness to have the idea whether there is any injury to the SIS or at a structure or not. This is the method. And while you palpating the SIS, to have the point for comparison of the triangle, drawing the triangle, you should use the thumb, first body point touched. And while you palpate, you should use all your fingers, whether it is irregular or tender or not, compared with the other side.
Sir, another thing, could you please explain the palpation of SI joints, sacroiliac?
Oh, sorry, SI joint. SI joint. Okay. SI joint. SI joint, actually, it is in, if you examine the patient in prone position, that is the venous dimple marks the posterior superior iliac spine. And if you connect both the posterior spine, it crosses the SI joint on both sides and along the sacral too. So if you go on palpating along this line, if SI joint is tender or inflamed, which happens in ankylosing spondylitis and tuberculosis, it will be tender.
Okay, sir.
Sir, another question to Professor Chinmay Desai, sir. How to differentiate between broadening, thickening, and irregularity of the greater trochanter?
Okay. So for the greater trochanter, for bony palpation of the greater trochanter, first you have to identify, as already Professor Pal has told, that you go straight from the highest from the iliac crest, go down, and first bony point palpated, it is the greater trochanter. And when you palpate the greater trochanter, always you compare with the other side. So there are 5 points you have to examine. One is examine the surface, it is irregular or not compared with the other side. It is, while palpating the surface, you should use all your fingers. And thickening and broadening almost synonymous. Place your thumb on the anterior margin of the greater trochanter and index over the posterior margin of the greater trochanter. And can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. So on both the sides, you just place your thumb anteriorly and index posterior to the greater trochanter and compare whether it is thickened or broadened or not. This is the 2 point. And third point is tenderness, whether it is tender locally or it is tender by pressing or mitochondrial compression when the hip is pathological. And last point is comparison of the level. That is, you place your all fingers perpendicular to the surface at the apex of the trochanter, and you can compare whether it is at the same level or high level. So 5 points: surface irregularity, thickening or broadening, superficial tenderness, mitochondrial compression, and comparison of the level.
Yes. Rajesh Goel, sir. Yes.
May I add something? Sir has broadly explained each and everything. But for one tip I would like to give to the students, that the posterior surface of the greater trochanter is very well palpable. So you should try to get the posterior surface of the greater trochanter, which is easily palpable, and then you can come over the anterior surface and you can see the broadening is there or not. You can very well see the broadening. So the posterior surface, from the posterior surface, you can come to the anterior surface, you can get hold of the trochanter, and you can see and you can compare from both the sides whether it is thickened or not, whether it is broadened or not. And then for the tenderness, he has very well explained each and everything. Thank you.
Arnav, can I show a video?
Can I show a video? Yes, sir.
Yes, sir. Please go ahead.
Yes. Is it visible?
Correct the screen.
Is it visible?
No.
No, video is not visible.
It is not visible?
No, sir, you have to select the
No, you have to allow me to share the screen, otherwise it will not.
Yes, sir.
Yes.
It is visible, but not the video. So you share it and select the video. Once you play it. After
Yes, I have selected it.
You start the
I have
play.
selected.
Then start again.
It is already running. Is it not seen?
No, sir. You need to select the video, not the window. So what you do, you stop your share, you play your video, start the share and select the video.
Okay.
You play the video.
Now I have already started. Then we have to share it.
Yes, share and select the running video.
The video which is running in background.
Okay, you have shared it, but it's not visible, huh?
No.
Select the video and if it is not in PowerPoint, it's difficult enough.
Okay, leave it. I have it.
MM Rai sir, it's audible now. MM Rai sir has joined.
See, I can hear also.
Yes, sir. Yes, sir.
I do not know whether I'm audible or not.
Yes, sir. You are audible.
Okay.
So, Rajesh Goel sir, one question is there from Odisha. So, how will you describe range of motion in examination? Suppose the patient is having 15 degree of FFD. So, how will you tell to your examiner what is the range of motion?
We examine the patient. If there is a fixed deformity, then the range of motion is from the fixed deformity to the full flexion or full movement of that particular range. If there is no fixed deformity, then the range of motion starts from 0 to what is the terminal range of that motion. And then we can divide it into whether it is pain-free or whether it is painful. If it is painful, then how much range is painful and how much range is pain-free. That's right.
And how do you differentiate between synovitis and arthritis while doing range of motion?
Yeah, in synovitis, the range of motion will be more. And in case of arthritis, all the movements will be restricted in case of arthritis.
Also,
not only that will be the synovium remains at the periphery of the joint. So if it is in front, the peripheral part of the range of motion will become painful. Okay, but if it is arthritis, all components becomes inflamed. So whatever range of motion is there, is very little amount of range of motion. Whole arc should be painful. Suppose in a synovitis, the hip joint, the reflection should be normal range is 0 to 140. For the synovitis, it may be 10 to 120 degree. So the terminal part, that is a 10 to 20, it becomes painful, and 120 to 130 becomes painful. But if it is arthritis, suppose there are some 30 degree to 70 degrees range is present. 30 to 70 degree whole range becomes painful. So that is the whole arc is painful with arthritis. The peripheral part of the range of motion is painful. This is synovitis.
Sir,
Sir, there is a question.
In other words, in arthritis, that even with a single degree of movement will be painful to start with, but not in the synovium. Synovitis at the terminal part, but in arthritis, from the very beginning, at any degree of movement will be painful.
So that is the take-home message. The terminal movement is painful in synovitis. Whole range of motion is painful in arthritis. Remember, sir, there is another question with Sumit Sural. I think you can answer this. What is the difference between short leg and Trendelenburg gait?
Can you repeat the question?
How will you differentiate between a short limb and a Trendelenburg gait?
Not.
So not any one of you, sir, want to take this question?
I think this is very simple tip. Is we have to see the shoulder. If you see the shoulder, if the shoulder is coming up and down, or it is lagging like this. It is looking like this. It is so. It is up and down. It is a short limb gait. Short limb gait. It is swaying like this, and this swaying is more on the affected side. That indicates it is a Trendelenburg gait.
Sir, another question.
Another point. Another point. Differentiate between the short limb and Trendelenburg gait. Actually, if you inspect, it almost looks alike. But if you go for test of the Trendelenburg test, in short limb gait, Trendelenburg test will be negative, and in Trendelenburg gait, Trendelenburg test will be positive.
Yeah, that is on.
Yes.
Yeah, Arnav.
Why 30 seconds is prerequisite for the Trendelenburg test? Why 30 seconds? Many people wants to know the reason. So anybody can take this question.
Any of the faculty can take this question. Yes.
Why 30 seconds?
Yes, actually, this 30 seconds is the reaction. It is a minimal time to see the reaction and to compensate. Actually, the muscles require compensation. It requires only 30 seconds, minimum 30 seconds. It may require more, but minimum 30 seconds is required to show the action of the muscles. Okay, so that is why it is 30 seconds.
Is the compensatory action.
Yes.
Sir, please explain the basis of sectorial sign once again.
Sectorial
There is
sign.
a question from one PGT.
Sectorial
sign.
Okay.
Please explain once again.
Yes. Okay, I'm explaining. So actually, what happens in avascular necrosis? Basically the anterior-superior-lateral aspect of the femoral head becomes avascular. So that becomes died and ultimately becomes irregular. So what happens? The anterior-superior-lateral aspect of the femoral head, which remains outside the acetabular cavity, it remains irregular. That loses its sphericity. That becomes flat, or you can say, or becomes oblong shape. Different shape becomes altered. So as you can see here, the acetabulum cavity, if you look like this, so it is the posterior, it is the anterior, and it is the posterior. Okay, the posterior is much more covering than the anterior. Okay, so once there is a expressions here. So once you try to internally rotate it, it will come, and again it become averting against the acetabular. So once it is going inside it is inside the acetabular cavity. So now it is easily allow the internal rotation. You understand? So that is the basis. There is a cam effect actually. The excrescence or abnormal shape of the femoral head is averting against the anterior edge of the acetabulum in extended hip. But once the hip is 90 degree place, that abnormal femoral head is going inside the acetabular cavity. So that will allow the rotation. Once it is outside, there is averting against that acetabular cavity. Once it is going inside, that will allow rotation. That is the basis of sectorial sign.
Thank you, sir.
So
Next.
there is a question in measuring free range of flexion of the hip joint, how to stabilize the pelvis.
Okay. Anybody?
Yes. Rajesh sir, Chinmay, is anyone of you? Yeah. Rajesh sir.
Yeah. In measuring the flexion range of movement, most of the time you do not need to have but you just have to put your thumb and the fingers on the anterior superior iliac spine, and you can see how much is the movement. Whenever the movement is possible of the pelvis, then it is the ultimate limit of the flexion deformity. So at that point, you should stop, and then you should measure the range of movement of the flexion. That is the way.
Exactly.
Yeah.
Moinak, any other question?
One question is there from the first year PG team from Nepal only. He has got out. So what are the prerequisites for Thomas test? Any other prerequisites for Thomas test?
Yes. So prerequisites of Thomas test is basically the decompensation of the flexion deformity. Once there's a flexion deformity of the hip, that is compensated by the hyperlordosis of the spine. So if the spine cannot compensate of concealing that defect, so we have to understand. So how much flexion deformity can be concealed by the hyperlordosis? Basically, it is 30 degree. Up to 30 degree flexion deformity of the femoral head is concealed by excessive lordosis of the spine, so that normally pelvis remains anteriorly tilted 20 degree from its horizontal. If it is further anteriorly tilted by this hyperlordosis, so that up to 30 degree flexion deformity can be completely concealed. Nobody will understand there is a flexion deformity. You understand? So that is the basis of the hyperlordosis compensation in case of flexion deformity. But if the spine is diseased, either because of the ankylosing spondylitis or any painful condition of the spine, so there is no compensation at all. So there will be no hyperlordosis. If there is no hyperlordosis, so there is no basis of the Thomas test. This is the basic of.
Sir, one question was there regarding the axis.
Moinak. Prerequisite is patient should be examined in hard bed.
Yes.
And there should be free movement of the pelvis in sagittal plane, and there should be free movement of the hip joint on the unaffected side.
And good illumination.
I think we can show the video that Moinak sent us of Thomas test. That video can be shown. If you want, I can show it.
Yes, I can show.
Yes,
Please show this one.
How can it be done?
Sir, again, you have to first open the video, then you have to start the screen. First open the video.
First, we have to start.
First open
the video.
Then
Okay,
you
okay.
start the screen share.
First,
So
we have to open the.
Is that what is the axis deflection and how we can? Yes, sir. To do it. What is the axis?
Share screen. I've already done.
Yes, sir. Select your video.
Yeah, I've already shared. I've already shared it.
Now we can see your screen.
Arnav, if it is not in PPT, it will not come. It should be in PPT. Otherwise, it's very difficult.
Okay, then I'll show you.
It is not in PDF.
Yeah. Sir, I will
Another question.
The video down. I'll show the video of Thomas test. So, anybody, Moinaka, you can explain?
Yeah, Moinak, explain it.
Yes. Arnav is showing.
Yes.
Yeah.
Moinak, please describe.
Describe, Moinak.
Yes. So as Professor Palsar has said, the eye level should be at the bed level. Okay. And the soft mattress that is usually given with the patient should be discarded, and it should be a firm bed, and it doesn't matter whether you insert your palm with the palm facing downwards or upwards. It is better with the palm facing downwards so that the knuckles reach up to the level of the spinous process. Okay, and then once the hyperlordosis is confirmed, which indicates a fixed flexion deformity of the affected side, then the normal sided hip joint is flexed until the spinous process just touches the tips of the knuckles. At that point, the further flexion of the normal hip joint should be stopped, and at that point, the affected hip joint will come to rest in certain degree of flexion. We will try to extend that hip further so as to loosen any slack in the flexion, and the remaining amount of flexion which is left is the amount of fixed flexion deformity, and it is to be measured with respect to the bed. It is preferable that you do not move your hand from the backside of the patient until the examination is complete.
Excellent, Manak.
I would request our teachers to further enlighten on any point which I have missed.
No, you have done excellent. Just only one point. Just once if the normal limb is held by the patient, that is known as Thomas grip. Just we have to push, gentle push on the affected side, so that there will be no voluntary flexion. That is only. That's otherwise it is excellent.
Next video, Arnav.
Yeah, so we have our Oberst test. We have another video is there. So we'll show the Oberst test, and Moinagda, please explain what they're doing.
Also explain for indication, Manak, when it is done.
Yes, Oberst test is mainly for the tightness of the iliotibial. So we will put the hip joint through abduction, and the knee joint will be flexed at 90 degrees throughout the test. And once the hip joint is flexed and it is bit extended, then the hip joint we will release, that is, we will let go of the leg and then observe.
So another one is
absolutely.
So what is the inference?
Hello?
That is the thigh is not approximating with the normal side. Affected limb, affected thigh remains abducted. That is the positive. That indicates it is a positive test.
If there is no tightness, then the limb will fall back to normal position.
Exactly.
This is the video of the sectoral sign, which Professor Pal sir has explained very nicely already. In extended position of the hip and the knee, we will check the rotation, and we will again check the rotation in 90-90 position. If there is any discrepancy, it is indicative of some sort of mechanical block.
Okay, very good.
Sir, here I want to ask one question that has been repeatedly asked there. It's what is the axis deviation, and why, how we can correlate that thing with a sectoral sign? And
any of the faculty, please, axis deviation.
Yes.
Yes, actually what happens if you flex the hip, gradually flex the hip, normally the knee will go towards the opposite shoulder. Once you flex the hip, you can flex, you can move the knee joint towards the opposite shoulder. This is a normal reaction. But what happens in case of axis deviation? So actually the once you gradually flex the hip, the knee will go outside the body, away from the ipsilateral shoulder. So that indicates that if you increase your flexion, there will be gradual external rotation. So again, if you examine the rotational movement of that particular patient, there will be excessive external rotation at the cost of restriction of internal rotation, but the whole arc remains same. That indicates the epiphysis of the femur is shifted not only posteriorly but also inferiorly in a retrograde fashion. So in that retrograde fashion, so that it is coming in congruity only by increasing excessive internal rotation. Only excessive external rotation is required to keep the head inside the acetabular. You understand? So once you flex it, then gradually it becomes externally rotated to maintain the articular congruity. Am I clear?
Yes.
So this is not the axis deviation.
MM sir, would you like to add something?
No, I agree fully that what she has explained is okay. And about the next program, what about our next program?
Next, sir, we will discuss, sir. Right now, we are live on YouTube. After that, we will discuss.
There is another question from Nepal. What is the difference between fixed flexion deformity and fixed inflection deformity?
Any one of you, sir?
No, I can't get it. Fixed flexion deformity and
fixed flexion deformity and fixed inflection deformity.
I don't know, sir.
The question is that
What happens? There may be fixed flexion deformity, that is one. Second, there hip is fixed at 30 degree or 70 degree flexion. Either fixed flexion deformity is there, or hip is fixed at 30 degree or 50 degree fixed flexion. Okay. So if it is a only flexion deformity, so that means that the patient has flexion deformity, but there is a possibility of preservation of the movement of the flexion and also in other direction. But if you told that there is a hip is fixed at the 30 degree flexion, that means there is no movement at all. There is no only hip, there is only, it is fixed at 30 degree flexion and there is no movement is possible at all. So there are two terms. I don't think there are any other term. One is fixed flexion deformity, or hip is fixed at 30 degree flexion deformity, like that.
So there is one question from Coimbatore, Kamal Parida. What is modified Thomas test for bilateral hip pathology? Rajesh Goel, sir, if you can answer. Modified Thomas test for bilateral hip.
Well, for that you have to go for Craig's test or the Dyer's method, in which you have to keep the patient in prone position and let the fixed flexion deformity be there, and both the limbs should be dangling from the edge of the bed, and then you have to keep one hand on the spine, posterior aspect of the spine, and try to extend the one limb. And whenever you feel that the pelvis is moving, then that amount of extension will be the fixed flexion deformity. That is the method.
There is another method. There is another model. Yes, there is another method. If there is a bilateral hip disease, so there are another method. Suppose patient is very in a painful, severe painful bilateral hip disease, painless hip disease. If it is a painful hip disease, what you can do? Both the lower limbs can be elevated from the bed simultaneously, keeping the knee extended and keeping your one hand behind the in between the body and the couch. Okay, both the lower limbs is gradually elevated, so that at that point where there is no the exaggerated component becomes lost, then keeping that pelvis fixed at that position, just lower one by one of the leg till see at which condition the lordosis reacts. So it is very difficult. That is one. It is a very painful. If it is not painful at all, fix both the limbs, both the hip flex it at the same position. Fix it and keeping your hand in between the body and the couch till the lumbar lordosis is obliterates. Okay. Now you can gradually extend one by one of the hip, one by one. So at that position, suppose in the right side it is extended, and up to 30 degree extension, the lordosis appears. That is the flexion deformity of that side. Now flex it again and do repeat the test on the other side. So this is the modified Thomas test. Flex both the hip in simultaneously till the lumbar lordosis of the exerted component obliterates, then gradual extend one by one.
Okay.
I think we are done with all questions. Yeah.
Yeah.
I think two things are there. If you anybody can explain once more, is the Kothari's parallelogram. Whether any prerequisite for doing that, whether it can be done in bilateral, and how to interpret. That is the three queries I think many people having. And for Pal sir, there is another question for the default sign. If you could again show how to
Default, yes.
Default sign.
Default sign, yes.
Two questions we have.
Default sign is basically you have to keep your one hand on the greater trochanter and one hand just in the same manner once we examine the telescopic test. Okay, just in the like telescopic test, we have to hold the lower thigh or the upper part of the leg. Upper part of the leg is in this manner, and keep another hand on the greater trochanter. Now rotate it. Rotate the leg. So if with the rotation, say if the neck is intact, the greater trochanter will move like in this manner, like this. In this manner. But if there is a neck the non-linear of the neck fracture, it will rotate in this manner. It is in this manner. That's in a different way. In this, it will move in this manner. That means the rotational pattern will change. The rotational pattern of greater trochanter will change. That is, instead of the moving in an arc of a circle, it will move in a circular way in same axis of the shaft of the femur. That can be easily interpreted unless you examine the other side. The normal side, if you examine the other side, if there is any pattern of change of rotation of the greater trochanter along with the rotation of the femur, so that is the basis of the distal side. Is it clear?
Yes.
One is the movement will be more, another is the pattern will be more, pattern will be changed. As on the normal side, movement will be less, pattern will be different. On the abnormal side, whether there is non-linear of makeup, movement will be more and the pattern will be changed. So that is the basis of distal side.
Remember, sir, there is one question: how to do telescopic test?
First of all, you will have to take the patient in supine position, hip, knee, 90 degree, little adduction, and put your hand, fingers over the trochanter and one thumb on the anterior superior iliac spine. Then you push and pull. Okay, can you hear me?
Yes,
Push and pull. You will feel some movement over your fingers. If you find some movement that something is passing under your finger, then the test is positive. Am I clear?
Yes.
Or anybody can make it more clear?
No, sir. Good. Sir, why adduction? Or the question: why do you do adduction of this?
And if you do not adduct, you cannot palpate the trochanter properly. If you put it in neutral position, you will not feel the trochanter properly. Little adduction will help.
Especially adduction will provocate to dislocate. Adduction is the provocative maneuver to dislocate. Adduction is the provocative maneuver to dislocate.
Yeah, to make hip more unstable.
Yes.
Any other question? I think we are done with all the questions, and we had a very good participation from India, Bangladesh, Nepal, and Pan India. So thank you, sir. Any more question?
Just I request elaborate on the Kothari's parallelogram, then we'll sign it off. We have everything.
Non-union of neck femurs. Somebody asked.
Yes, sir.
Yes, sir. What is the difference between delayed union and non-union neck femur? Neck femur. I will explain.
Delayed union and non-union. Any one of you, sir, faculty?
Yes, I'm clear. Actually, question of delayed union and non-union neck of the femur arises only when it is operated. Okay, so once it is operated, then only this is as per Parker and Pryor book. In the textbook of Parker and Pryor, the question of delayed union and non-union is that both the terms simultaneously can arise only when it is operated. Otherwise, if it is non-operated, non-union can be stamped only one three months is elapsed, and there is no clinical radiological signs of healing. That in that case, there is no progressive clinical radiological signs of healing for consecutive 3 months. And in that case, the non-union of can be stamped up. But the delayed union and non-union can be considered once it is operated in the form of internal fixation. So if there is internal fixation is done, then there is no clinical radiological signs by 6 months. There is no signs of union clinically as also radiologically by 6 months. It is considered as a delayed union, and it is completely 1 year has become elapsed till there is no signs of union clinically as also the radiologically. That can be considered as a non-union. As per Parker and Pryor book, it is published in, I think it is first edition was 1992. Then I think this is the only copy I have, but that is a very good textbook. It is given. Otherwise, it is an untreated case. It is only 3 consecutive months is elapsed, but there is no clinical radiological features of union. That is considered as a non-union. And the Kothari's angle. That's the Kothari's angle is basically, it is very easy. So, that is basically, it is ML Kothari, he discovered it, and basically his basis is once there is a severe painful hip. So there is asymmetry of the anterior iliac spine. One side is below or up. That indicates that the abduction deformity. So in that case, we have to correct the deformity. But because of the severe painful condition, we cannot even move the 1 degree movement of the hip. So in those cases, how will you ascertain how much abduction or adduction deformity is there? So in that case, so first we have to make a midline point from the umbilicus to symphysis pubis. This is the first point. And another line is joining both the anterior iliac spine. Okay, so this is the second line, and the third line is from the ASIS of the both side to the midline vertical. So if it is a bilateral disease, but in both the cases there will be an angle between these 3 lines. That is the line joining the anterior iliac spine to the midline vertical, and also another line between the ASIS to ASIS. Okay, so this is the angle. So easily, I've already, it is my lecture also. So in that case, in the affected site, it indicates the actual abduction or adduction deformity. Even without movement of the hip, we can easily ascertain how much abduction or adduction deformity that can be corrected. Suppose in an ankylosing spondylitis, both the hips become very much ankylosed, we have to know which side is abducted, which one is adducted, so that it can be reciprocated during this operation. That can be easily can be done.
That is good for painful hip and bilateral hip pathology.
Yeah, bilateral, yeah.
Arnav, I think we should now end the session. Almost all the question has been answered, and thank you everyone. Thank you Rajesh Goel sir. Sumit Sural has left. He has to join another program. Thank you MM Rai sir, Chinmay sir, AK Pal sir, my friend Sabyasachi, Mainak, Arnav, and our.
Thank you very much from Rajasthan. I am really thankful to West Bengal Orthopedic Association for including me. Thank you very much.
Thank you, sir.
Thank you, Rajesh, for excellent organization. Thank you all dignitaries of the West Bengal Orthopedic Association.
Thank you very much.
Thank you so much, sir. And we have learned a lot today.
Thank you very much.
All right. अर्णव একটু এ করে দাও এমএম রায় স্যার কিছু বলতে চাচ্ছিলেন দেখুন এমএম রায় স্যার
अर्णव
अनम्यूट करो अर्णव
अनम्यूट कर নিজেকে
हाँ
yes so I request all the attendees that if you still have any questions or queries you can still comment it down below our video so that we can take opinion from our esteemed senior teachers and we can reply you back on
Yeah.
that. Okay, that's all for. So I'll request Chinmay sir and Parthu sir to conclude
the session
from their address.
I think Sir is not hearing the question. So thank you all. Special thanks to our faculty, especially Dr. Rajesh Goel, Professor Sumit Sural, Professor M.M. Rai sir, Professor Sekepal, and of course our President, Professor Chinmay sir, for making this webinar so lively that we have to able to get more and more participation from our postgraduate students. Thanks to our webinar committee for presenting such a useful webinar for our junior members. Thanks to all postgraduate students for their active participation. Again, thank you all. Thank you.
Thank you, sir. Thank you.
Okay.